our presentation for the day and discussions. Please feel free to interrupt any time during the conversation to ask any doubts or any questions if you have. We are always open for conversation, so feel free. Also, if you think there are certain things which have not understood very clearly, maybe you can even ask them later on also, or you can email, or you can put into chat, or you can ask in tomorrow's class as well. Right? Fine. So maybe I'll request all of you to mute your microphones. Kindly mute your microphones. Good. So do you see something on your screen now? You see a beautiful kid and father. Look at the love in their eyes. And this is today's patient who came to us. Her name is Pretty Priya. Like she looks is her name. So Pretty Priya is about 4 years of age, and her father brought to her with the complaints that she has got fever since 3 days. She perhaps is having headache. At 4 years, the child is not really able to say the child has headache, but child usually shows it by holding the head, just holding it like that, so that you can make out the child is having some issue with the head. So fever, headache. She is not eating well, and whenever she is trying to eat, she feels pain in the throat. So these are the complaints with which the child was brought to Sanjeevani Clinic. And at Sanjeevani Clinic, someone saw her and thought, what could be the diagnosis? Maybe some kind of a throat infection. So they said maybe viral infection or maybe something else. So the patient was given an examination. When they looked into her throat, they found that the tonsillopharyngeal area was congested. There was whitish coating on the tonsils, and when you palpate the cervical lymph nodes, palpable, tender, both in submandibular region as well as in the vertical limb. So that brings us to a question as to what are the lymph nodes in cervical region. I hope you have been told about. If you have not been told, even then it's worthwhile right now to get into your anatomy books, look for the distribution of lymph nodes in the neck, draw a neat label diagram of the lymph nodes in the neck with relation with other structures. Those diagrams are already there in your anatomy books, and names of those different lymph nodes like submental lymph node, submandibular lymph node, and so many of them are there, and the area where they come from. It's important for us to know the area of drainage of each lymph node, because if you palpate a lymph node, maybe in the submental lymph node or submandibular lymph node or any of these cervical lymph nodes, if you palpate a lymph node and if you find it palpable, tender, enlarged, you can look back that this lymph node drains this particular part of the body. Therefore, the infection must be occurring in that part. So you just have to go to the part where it is drained from. You can be even smarter than that and impress your patient by palpating a particular lymph node and then saying, okay, this is the area where it is draining. So ask your patient, do you have any problem in that area? And patient will be amazed. My God, this is an intelligent doctor. Look at it. He didn't even ask me to open mouth, but he could tell where the problem is in my mouth. A really great doctor. And this is what makes great doctors, by putting your theoretical knowledge into practice. So task for you all is, please note down, draw neat label diagram of cervical lymph nodes with related structures. You can copy that from your anatomy book, and the area drained into each lymph node. And this must be always over here in your mind. so that you can use it for your practical clinical purposes. So child had tonsillopharyngeal congestion, submandibular and cervical lymph nodes were palpable, and this is how the throat looked like. So this is the uvula and this is the pharyngeal arch, and you can see congestion, redness and blood vessels. Is it normal or abnormal? That is what you need to know. So how will you find out? Very simple. You got people at home, take a spoon, use the flat side, the handle of the spoon to depress the tongue and look into each one's of throat with good light exposure. That will show you as to what is the normal structure of the throat and what is abnormal. The doctor's job is to diagnose, and diagnosis occurs when you can differentiate between normal and abnormal. When you differentiate abnormal, that becomes your diagnosis. So today, tomorrow, day after tomorrow, next 5 days, you keep on practicing looking at throat of everybody in your house, but make sure that you wear a mask so that you don't get infection, and observe as to how the throat looks like. Don't go outside. Don't expose yourself to strangers' throats because that may carry virus. So the diagnosis of acute pharyngitis was made, and Pretty Priya was given paracetamol to reduce her fever and body ache, some anti-allergic, antihistaminic tablets to reduce the congestion, and she was giving erythromycin. And she was told, take it for 2 days, and after 2 days, come and show me. Pretty Priya took this treatment, mother gave her this treatment, and in 2 days' time, she thought Pretty Priya has become better. She doesn't have any fever because of paracetamol, perhaps, and she is able to eat. She is feeling better. So, since mother was a farmer, father was a farmer, they had lots of other things to do. They said, okay, baby is okay now, let her be at home. Treatment was discontinued. Now, any treatment which is started must be taken to its proper conclusion. If you want to discontinue treatment, it is best to consult. But problem with our country is consulting with a doctor costs a lot of money for the parents, and many parents who are day laborers or workers, if they go to the doctor, they lose one whole day's salary or one whole day's wage, and therefore they are not able to afford that. So many of the people do not take complete treatment. So what happens? For 2 weeks, Pretty Priya was all right, but after 2 weeks, she again had more or less similar symptoms: pain, fever, headache, not eating well. Parents were smarter at this time. They say, oh, she's having the same problem which she had last time. I have some of the medicines left with me. So whatever leftover medicine was there at home, they gave her the same medicine. She responded. So parents were very smart, very happy. They felt, okay, we have saved a lot of money of going to doctor and buying the medicines all over again. Same medicines we have kept. We'll use the same medicines if she gets unwell or anyone else gets unwell like that. And that is something which even you people follow, isn't it? Someone gets unwell in the hostel, other fellow says, oh, I also had similar thing. I had taken this medicine, you also take this medicine. I have left some leftover with me. This is a very common practice in our country, in our society. Unfortunately, it is not a very good practice because many times we miss out on the diagnosis, we miss out on the proper treatment, and the patients do not get proper treatment and lead to complications. So Pretty Priya had 2 episodes of throat infection. Both were treated for 2 days. And this is what happened when she came next time. Again, or this is what we had seen. The throat was there. This is a diagrammatic representation, and the tonsils showed whitish patches over there. Now, if you look at the first, you don't see any tonsils over here. Why don't you see tonsils? because the tongue has not been depressed. So if you want to examine the throat, make sure that you use something to depress the tongue and ask the patient to say ah. While speaking that, the tongue also gets depressed, and then you have a better look at the posterior pharyngeal wall as well as tonsils. Otherwise, you are likely to miss this diagnosis. And this is what happened in case of Pretipriya, that this whitish patches on the tonsils were not noticed by the person who treated her. So what happened? 3 more weeks passed, and Pretipriya then came back to the doctor. This time she had pain in the knees. She also had fever. She also had anorexia. Someone told her, don't worry. Told her mother, don't worry. You just take paracetamol for pain and give some hot fomentation to the knees. The pain will disappear. And sure enough, the pain in the knees disappeared and came into the ankles. So the wise neighbor told her, look, I have told you, once you give hot fermentation, the pain will go. Now it has gone from knees into the ankle, and slowly it will get down into the ground. Something like electric current, grounding. So that's what was expected. And she continued to have fever, pain, anorexia. And then after a few days, her parents noticed that she has got tiny swellings on her arms and legs. These were not painful swellings. What happened was, when mother was giving a bath to the baby, she noticed that there are some lumps present on the arms and legs. But they were not painful, so she did not pay much attention to that. So Pretipriya kept on getting well, kept on getting ill, kept on getting well, kept on getting ill. This on and off fever pattern continued for 3 months. And then she was brought to our clinic again with the complaints of cough, breathing difficulty, swelling on the face. And when we examined, we found that she was tachycardia, pulse was 120 per minute, and pulse was irregular. On auscultation of the chest, we found that she had crepitations in the pulmonary region or on the chest. You have not yet used stethoscope. Have you used a stethoscope? You can unmute and answer. Have you used the stethoscope? No. Do you have a stethoscope with you at home? Anyone has stethoscope at home?
Yes, sir.
Okay, so if you, all those who have stethoscopes at home, please use it. There's no point in having a stethoscope and not using it. So put the earpiece in your ear and put the chest piece on your other family member's chest, in the back, in the front, on the scapula, between the scapula, over here in the shoulder, on the just above the shoulder, in the fossa, and try to listen to different sounds that you hear. It's amazing experience. You will take some time to understand those sounds. And what we heard in Pretipriya's chest was what we call as pulmonary crepitations. When you come back over here, we'll do some experiments by which you can hear pulmonary crepitations. But meanwhile, keep on getting familiar with the normal heart sounds and normal respiratory sounds using your stethoscope. Since her pulse was high and pulse was irregular, and ECG was done, which showed prolonged PR interval. I think you have been taught about ECG in physiotherapy, in physiology. Have they taught you?
Yes, sir.
Okay, so I don't have to go into detail. Just look into the causes of prolonged PR interval. What is PR interval? What does PR interval represent in ECG? And what are the causes of prolonged PR interval? So that you should know what pathology is occurring in Pretipriya's heart. So this shows that Pretipriya is having something which is affecting multiple systems. She is having fever, that means there is some systemic inflammation. She is having cough and breathing difficulty. That means something wrong with the pulmonary system, respiratory system. She's got swelling on the face, maybe something wrong with the cutaneous system. Her pulse is high and prolonged interval PR. That means something wrong with heart. So she has got cardiac involvement, she has got respiratory system involvement, and she has got systemic fever. So what do you think Pretty Priya is having? Something which is involving multi-systems. So what is happening to Pretty Priya? What should we be thinking about? Because this is how your patients will come to you. This is differential diagnosis. Can anyone suggest what might be happening? Before you go into clinical diagnosis, you must go into the pathological diagnosis. We have done anatomical diagnosis, that different systems are involved. Now, pathological diagnosis is inflammation as shown by fever. So, multiple systems inflammation, multisystemic inflammatory process is happening. Now, we have to find out the cause and give it a name. And that name is acute rheumatic fever. So we are going to talk about acute rheumatic fever, or we should rather call it acute rheumatic disease. And then we will also look into the consequences or sequelae of what happens if the rheumatic fever continues. So we have a look at this. You already are aware about this definition, that it's an immunological sequelae. It's a result. It's not infection itself, but it's a sequelae. It's a consequence. It's what happens after acute streptococcus group A infections of the throat, primarily throat, sometimes maybe of skin also. And this is manifested by varied clinical features, as we had seen, respiratory system features, cardiovascular system, cutaneous system, and systemic infection or systemic inflammation as fever, and it may have long-term consequences. So this definition is what you need to remember. It's an immunological sequelae of acute streptococcus group A infection, leading to manifestations and long-term consequences. And what are the clinical manifestations? We can systemically divide them into systemic manifestation as fever, involvement of the joints as arthritis, involvement of the cardiovascular system, involvement of the central nervous system, and also dermatological involvement. So all involvements include 5 different systems in our body. You are familiar with group B, group A beta hemolytic. This is blood agar plate. These are the colonies of streptococci, and this clear zone is the beta hemolytic zone around the streptococci. So these are the culprit organisms, but we should not be calling these organisms as a culprit, because the streptococci do not cause this problem. The problem is immunological. So what really happens? Before that, let's see how often this happens. About 5 to 10 people per 1,000 population suffers from this particular infection. Now, streptococcal infection is much more commoner, but sequelae occurs only in about 5 to 11 per 1,000 population. An usual manifestation occurs between the age 3 years to 20 years. Why 3 to 20 years? Why not earlier? Peak is around 6 to 10 years. The reason for that is, before 3 years of age, the child is mostly at home. So the child is unlikely to get streptococcus A infection, because that infection comes either from other children in the school, or by playing with the children, or from siblings. So before 3 years of age, this infection is not so common. But when the child starts going to school or starts going outside and playing with other children, then the cross infection occurs and the child gets streptococcus infection. And then When this infection gets treated, untreated, untreated, treated, partially treated repeatedly, it takes few months to years, and therefore the manifestations occur in about 6 to 10 years time. This is more severe in girls. That's something to notice. Mostly, most of the diseases are less severe in girls. They are more severe in boys as compared to girls. Why? What is the genetic difference between boy and a girl? What chromosomal difference is there between a boy and a girl? Can anyone say?
23rd pair of
2X chromosome in female and
And
1X and Y chromosome in.
so what is the Y chromosome? Y chromosome is actually an X chromosome whose one leg has been cut off. So it's a deficient chromosome. Two X chromosomes offer more protection to the girls, while Y chromosome does not offer that much protection to the boys in most of the cases. But in case of rheumatic disease, unfortunately, it is more severe in girls, more common in girls. We still do not know what genetic factor determines this. Maybe something to do with autoimmunity. There are lots of familial and genetic and environmental factors. Environmental, we have just seen children who play with other children, children who have to live in congested locations, children who are exposed to large number of other children are more likely to get infection. But it's not only getting infection. Everybody gets infection. You have got infection, I too have suffered from this infection. But only small proportion of us go into rheumatic disease because there are some kind of familial and genetic underlying conditions as well. We still do not know what they are. There have been some guesswork about it that certain HLA types are more predisposed to rheumatic disease. So HLA DQW2, DR3, homologous B cell alloantigens D817. These are some of the genetic markers which are found to be commonly associated with rheumatic disease, but we really do not know what role they play. But there is some genetic predisposition and there is some individual susceptibility. There is also involvement of particular type of streptococcus. The serotypes 1, 3, 5, 6, 18 are the common one. If any one of these or more of these cause infection, person is more likely to get rheumatic fever. If person is not infected with these strains, rheumatic fever is unlikely to happen. Also, to great extent, how promptly the diagnosis of streptococcal infection was made and how promptly it was treated. That's also important. So 5% of all infections of streptococcus can lead to rheumatic disease, and that proportion is much higher in Nepal and India. So we see a very large number of children suffering from rheumatic disease and its consequences. So what happens in rheumatic disease? The streptococci carry some antigens. So our body immune system, as we had studied, the adaptive immune system produces antibodies against the antigens present in the streptococci, and those antibodies go and destroy streptococcus. Wow, so far so good. It happens in most of us. But in some people, it goes one step beyond. And that step beyond is that the M protein present in the wall of streptococcus has got structural similarity with the antigens present in various connective tissues. These connective tissues could be in the skin, could be in the myocardium, could be anywhere else, and wherever in the joints or anywhere else. And wherever these similar antigenic structures are present, the antibodies, instead of killing only the bacteria, go and attack that tissue as well. So it's a kind of autoimmune disease in which our own antibodies under mistaken identity, attack our own connective tissue, thinking that the antigens in this connective tissue are actually streptococcal antigens. So this is a case of mistaken identity. So the antibodies against streptococcus antigen go and react with connective tissue. When antigen antibody react with each other, it leads to inflammation. Inflammation has got both phases, proliferative phase and exudative phase. I think pathologists must have told you in great detail about it. And those phases ultimately lead to lots of cytokine production and lots of tissue damage. It's something like two persons start fighting, they start throwing stones on each other in the street, and those stones, instead of hitting those people, start hitting the glass panes, window panes of your houses or surrounding shops, etc. So instead of the people who are fighting getting injured, there is a more of a collateral damage. Same thing happens in rheumatic disease, that the antibodies, when they act against the antigen, they lead to inflammation, and the inflammation not only destroys the antigen present on the tissue, but it also produces lots of cytokines, and it causes lots of structural damage to the surrounding tissue. And whenever a tissue is damaged, whenever its structure is damaged, its function also is abnormalized. So there is functional abnormality as a result of structural damage. So structure is damaged, function is abnormal, obviously it will manifest as a disease or as a clinical manifestation. We have seen Pretty Priya had trouble in the joints, she had trouble with her heart, she had trouble with her skin, and these are various antigens present. The antibodies against them, if they are present, will attack those places and will cause problems. So when vimentin is damaged, there is joint involvement. Laminin, cardiac valves. Keratin, skin. Tropomyosin, myocardium. So depending on which particular tissue is damaged more, there will be clinical manifestation. It is not necessary that everybody will have cardiac involvement, everybody will have skin involvement, or everybody will have joint involvement. Some patients may present only with fever, some may present with fever and joint pains, but they may not progress to heart disease, or some may not have joint pains at all, may suddenly present with cardiac involvement. So variety of combinations of disease, combinations of symptoms and signs can occur depending on which tissue is cross-reacting with the antibodies against streptococcus. So let's have a look at pathology. I guess pathologists must have told you in greater detail. We'll just briefly go over it, that there are proliferative and exudative perivascular inflammation. That's very important. Inflammation occurs around the blood vessels in the connective tissue of joint, heart, brain, etc. And then there is an exudation. That means there is an effusion, there is a fluid in the joint capsule or in the pericardial space or in the pleural space. When there is effusion in the joint capsule, it leads to swelling of the joint. We call it effusion in the joint. When it occurs in the pericardium, we call it pericarditis or pericardial effusion. When it occurs between the two layers of the pleura, we call it pleural effusion. That is the part is the exudative part. Now, after exudative part, there is a proliferation of the cells, and that can lead to Aschoff nodules, particularly more commonly on left atrial myocardium. We'll not go into detail of Aschoff nodule, but I'm sure the pathologist would have shown you the slides or will show you the slides of Aschoff's nodules and what histopathological changes occur in rheumatic disease. So just to sum it up, person suffers with acute sore throat, which may be treated, untreated, or partially treated. If it is treated fully, streptococcus disappears. But if it is partially treated or untreated, the streptococcus may remain there, and depending on the duration of infection, after about 10 days or so, the immune response occurs and the lots of antibodies are produced against different antigens of streptococcus. These antibodies are the beginning of rheumatic fever. If the infection persists, more and more antibodies get produced. If infection disappears, antibodies will also disappear. But if the person gets repeated infection, that means immune system is repeatedly stimulated to produce more and more antibodies. Now these antibodies cross-react with our tissue, lead to rheumatic fever, arthritis, cutaneous, nervous system, or cardiovascular manifestations. So let's look at some of the important clinical features. Patient will come to you with history of acute streptococcal pharyngitis, history of pain in the neck, difficulty in swallowing, maybe change in the voice, fever, headache, maybe some palpable lymph nodes, and after some time, the patient may complain of pain in the joints. Now, these pains are not in the smaller joints, always in the bigger joints. Bigger joints. Bigger joints are knees, ankle, elbows. And we had seen in case of Pretty Priya that the pain initially started in the knee joints and then it migrated. It disappeared from the knee joints and started in the ankle joint. Now, why does this happen? The inflammation, once it starts into the knee, why doesn't it remain only in the knee? It disappears. The pain swelling in the joint suddenly disappears and another joint involvement may be seen. Why this happens? We are still not sure. But this type of arthritis or arthralgia is called migratory arthritis. It migrates from one big joint into another big joint and may last for 3 days to 7 days and may suddenly disappear without any change, without any effect, without any prolonged effect on the knee. So that's a good part of joint involvement, that whatever happens, happens for a short duration. But in those 7 days, the patient is awfully sick. You just barely touch the knee, which is swollen, the patient will cry in pain. It's so painful. It's swollen, red, big, bulky. Patient cannot bend, patient cannot walk, patient cannot sit. And patient should ideally be kept lying in the bed without touching the knee at all or without touching the ankle at all, wherever there is pain. So this is an example. Can you see the difference between the two knees? This knee is absolutely fine. You can see the patella very clearly. Over here, the whole knee is red, swollen. You can't see the patella properly. And if you just manage to touch this, touch gently, patient will howl in pain. So that's rheumatic arthritis. Redness, swelling, and pain and loss of function. Classical features of inflammation. In some patients, though uncommon in Asian, there occurs what is called as cutaneous manifestation in the form of erythema marginatum. As the name suggests, erythema means redness. Marginatum means something which keeps on spreading along the margins, not in the central portion, but only in the periphery. This is not common amongst Asian, but sometimes it can be seen. It appears primarily on the trunk and spreads upwards and outwards. There are very clearly demarcated linings of the area and it keeps on spreading by hour, while the central area disappears or becomes clearer. And it is so rapidly progressing that you may notice it on the chest at morning 8 o'clock. By 12 o'clock, it would have reached the collarbone. By 2 o'clock, it would have reached the mandibular region. It becomes worse when the person is exposed to heat or sunlight, and this is commonly seen in Caucasians. not in Asians, but Caucasians. People whom we call as Firang or white people or colorless people. This is where more commonly seen, not so common amongst pigmented skin. Interestingly, it stops at mandible. It never goes onto the face. It may come up to the neck, but will never progress onto the face. Is there some difference in the skin of the face and skin of the rest of the body? Yes, there of course is difference. But what is that difference which stops spread of erythema marginatum at mandible? We are not really sure about. See, there are so many Nobel Prizes lying if you just investigate into these areas. Get into research, find out what are those reasons, why ankle joint and knee joint get involved and why not smaller joints, why migration of the pain occurs, why erythema marginatum does not spread onto the face. So many things to find out. And this is what the erythema marginatum looks like. It looks like the map. You can see the boundaries which are red marked, and you can see the clear areas in the center. Over here on the scapula, there is a clear area. On the right scapula, you can see the boundary of the map, just like the boundaries of certain countries, while the central area is clear, and it keeps on migrating right up over here, but it will not cross and go onto the face. So these are the two important manifestations: fever, joint manifestation, and skin manifestation. One more skin manifestation which occurred in case of Pretipria. Now you remember, Pretipria did not have erythema marginatum. Asian skins, pigmented skins do not get erythema marginatum. But Pretipria had subcutaneous nodules which occur about 3 to 6 weeks after the onset of the disease, and these are painless nodules. So patient does not notice it. Maybe sometimes parents notice it, particularly when they are changing the clothes of the children or when they are giving them a bath. And unfortunately, in poorer family, in lower socioeconomic strata, taking bath and changing clothes is not as frequent. So many times this is missed. Because there is no pain, the child does not notice it. It's painless. It can start as a small nodule and it can keep on increasing in size, almost to the size of an almond, badam. That means about 1 to 2 centimeter in diameter. This also is a temporary. It appears and it disappears. But what is interesting is that if it keeps on increasing in size, that means patient is going to have more and more complications. If the subcutaneous nodules are small, tiny pin size, excuse me, and they disappear quickly, that means patient is not going to have more complications. So there is a prognostic value in subcutaneous nodules. So every time a patient comes to you with history of fever, pain in the joints, not feeling well, don't forget to examine the skin. Just take out the clothes, palpate the skin all over, have a look at the arms, legs, back, chest, abdomen, everywhere. If you find nodules which are painless, mark it with a pen, tell parents not to wash that area and ask them to show you the child after 2 more days. If the size of the nodule has decreased, very happy. Patient is not going to have complications. If the size of the nodule increases, well, that's something for you to worry about, that the patient might land up with complications. So this is how the subcutaneous nodule appears. It is more easy to palpate than to see, because to see it has to be very big or reasonably big, but palpation, when you move your arm gently, when you move your hand gently over here, you will suddenly realize that there is a nodule which is firm and non-tender. So subcutaneous nodule is another skin manifestation which we need to keep into mind. Okay, so we have seen joint problems, we have seen skin problems, and what is this? What does it remind you of? One very famous personality. Any guess? Anyone would like to name that person
Michael
by
Jackson.
looking? Michael Jackson. Very good. Very good. It reminds me of Michael Jackson. Look at the movements. Look at the hands. Look at the legs. Look at the bend at the knee. Look at the ankle. Look at how he's making his left foot go up at bend at the knee and balancing at the same time twisting. So all these types of things Michael Jackson did, but unfortunately, a patient of rheumatic disease, when he starts getting such movements, it is called chorea. So, chorea is abnormal, repetitive, purposeless, involuntary, jerky movements. Patient doesn't do it purposefully. Suddenly, patient's hand goes up and moves like this. Suddenly, another arm goes into another direction and starts making some weird, involuntary, jerky movements. Whenever I used to see Michael Jackson dancing, I used to feel that perhaps he has got chorea and nobody has diagnosed him. But he made billions out of that chorea. Again, like rheumatic disease, neurological features also are more common in female as compared to male. And these jerky movements could be one-sided, could be generalized, and sometimes it can give a very odd shape to the outstretched hands. Many times, these jerky movements are for a few seconds or few minutes, and therefore, patients don't really notice it, or parents don't really notice it, but the teachers notice it because if the child is writing something, the handwriting becomes illegible. Some child who used to have very nice handwriting, suddenly his handwriting worsens. Please make sure that you investigate the child properly. That is the child suffering from jerky involuntary movements, purposeless movements, unintentional movements, which could be causing his handwriting to become bad. And that could be one indicator for you to find out if the child is having other features of rheumatic disease. Luckily, like the cutaneous manifestation and like the joint manifestation, in about 2 to 6 weeks, this disappears. So sometimes what happens is the child who has been doing well in the school, his handwriting gets spoiled. The teacher starts punishing the child, tells the child to write more and more and more, and sometimes even whacks the child. And after 2 to 6 weeks or so, the child's handwriting improves and the teacher pats herself or himself. Wow, look at it. I am so good a disciplinarian that such a bad handwriting I have improved within 2 weeks by putting discipline in this child. Perhaps the teacher did nothing but to make the life of a child miserable because the disease was self-limiting itself. So these are the possibilities which can happen with handwriting, with nodules, which are what we should be looking for. We should not be waiting for patient to go into rheumatic heart disease, but we should be diagnosing patients at early stages by looking at their handwriting, by looking at their movements, by touching their skin and seeing that they have nodules or no, looking at their joints and so many other things. Because if we don't do that, the patient is going to land into something much more serious. So we have seen three important manifestations of rheumatic disease: the joint manifestations, the cutaneous manifestations, and the CNS manifestations. Luckily, all these three manifestations are reversible and they reverse by their own. Whether you treat or you do not treat, the patient will improve. But the problem occurs with what we are going to see subsequently is that if we don't take action in time, the patient may have irreversible changes occurring in some other parts of the body. What changes? What problems? What can it lead to? Well, we'll keep it for tomorrow, isn't it? We'll see it next time. Your next class is on 5th. So 5th morning, We'll continue the story of Pretty Priya as to what happened to her, because if she remains undiagnosed, what will happen to her if she is diagnosed and treated? What do you want to do? You want to diagnose and treat her and prevent complication, or you want to study the disease in greater detail to see what complications she can go through? Choice is yours. We'll talk about it in the next class. But meanwhile, if you got any doubts, any issues, any thoughts, and you want to tell me something or you want to ask something, please feel free to ask. So we are open for any questions. Anyone would like to have question, please feel free to ask up till now. Any questions? Any doubts? Anyone? Avigya? Bravin? Ranju?
Sir?
Any doubts? Any questions? Or
No,
are
sir.
things clear? Okay. So what I would suggest is, please read this topic also about streptococcus and rheumatic disease from your books, and then we'll discuss remaining part day after tomorrow. Meanwhile, take care of yourself, but you have got some homework. One homework about cervical lymph nodes and their drainage area. Number two homework, examining the throat to get understanding of the normal appearance of the throat and how to distinguish it from abnormal. And three, start using your stethoscope. After all, you're going to be a doctor. And if you have a stethoscope, you better learn how to use it effectively. So three important works for you to do over next couple of days, and we'll meet on 5th morning. Till then, take care, stay safe, take all the precautions. Bye bye. Good day.